All right, today's guest is tackling one of the biggest blind spots in physical therapy, pediatric manual therapy. Now, for decades, we've borrowed adult techniques and, well, just crossed our fingers because clear evidence-based guidelines for treating kids simply don't exist. Our guest is changing that. She's an educator, researcher, and pediatric specialist whose work focuses on chronic pain in children and the safe, effective use of manual therapy for a growing musculoskeletal system. She's developing new techniques specifically built for kids, not scaled down adult care. And she's helping train the next generation of clinicians to approach pediatric patients with confidence, compassion, and #science. If you've ever wondered how to actually mobilize a child's joint safely, how parent beliefs and trauma influence chronic pain in kids, or why participation, not just range of motion, should be your primary outcome, this is the conversation you didn't even know you needed, but you do. Ginny Henderson is here to fill one of the biggest gaps in our profession, and I can't wait to dive in. We bring her in. Ginny, welcome to the show.
Thank you.
How was the intro? Did I do all right? Did I hype you up well?
You did really, really well. Yes.
Perfect. All right, let's dig into this. There's a special place in my heart for pediatric physical therapists. I posed as a pediatric physical therapist for a year, about a year out of PT school. Loved it. The impact, it was very difficult to have a bad mood. I'm not saying a hard day. It was very easy to have a difficult day, a lot of work. But at the end of a day, in the middle of a day, and even when you crawl out of bed, it did feel rewarding. It was a very clear path to rewarding. So thanks for doing what you do and focusing on pediatric patients, not tiny adults. That's what my mentor taught me. Amy said, they're not small, they're not tiny adults.
They're not. So
what made you first realize that pediatric manual therapy has a major gap in clear evidence-based guidelines? What was that moment? And then you just took it upon yourself. You're like, all right, this is my fight. I'm going to dive in.
Sure. So I started in adult therapy for my first 17 years of practice. And then my daughter had a heart condition, and we spent 6 months at Texas Children's. And I had that moment of, I want to do what these people do. I want to step into the lives and the stories of families. And so I switched over into peds. Well, at the same time, I was going through my manual therapy fellowship with MPI. And so I was doing both of these together, where I was kind of changing my way of thinking and trying to understand how the pediatric paradigm worked while learning all of these techniques and how they come together. And I realized that we speak two different languages in adult treatment versus pediatrics. And I would have coworkers come up to me and say, hey, I know you're in this manual therapy course. I've got this kid who had Botox to his adductors, and now when he abducts, he's getting a pinching pain. Is there anything you can help me do? And I'm like, yeah, let's invariglide him. And so we started doing that. But I realized that the way it was being taught to me and the way I needed to teach it to them was different. And when you look at the ICF model, pediatrics is much more participation and activity based. And they're not looking to say, how can I increase shoulder flexion? They're looking to say, how can I help this kid lift his arm to put his shirt on by himself? And so I knew the starting place was really looking at what are the goals of pediatric therapists. And so I started drawing the pump tool and then going, okay, what else do they need to know? Well, they obviously need to know red flags. And so really started to research those and put that together. And then at that same time, I was getting into pain, and the article came out on how to manual therapy for different pain types. And I was like, I could have written this. Like, I literally was already thinking about this. I wish I had been known enough to be included in that, because I would have loved to have been in that room. And so just really started putting all of that together. And then that's when I applied to the SCD at Texas Tech, and told them, they said, well, you'll need to do a dissertation. And I said, well, actually, I already have something I want to look into. Great. And sent that to them, and they just helped me really flesh it out and kind of take it to the next level.
Just so we don't leave the audience behind, what is the SCD? Walk them through that.
The Doctorate of Science in Rehabilitation Sciences. So Texas Tech has that program, and I chose that one because I knew other people who were in it, and I had heard great things about it. And so I kind of came in with this this piece that I knew I wanted to get other brains to think with me about,
Good.
and they had the people to do it. So
All right, so let's get into your not only research but clinical work. In your mind, what are the biggest misconceptions or mistakes clinicians might make when applying adult manual therapy techniques to kids? What are the things you wish you could erase?
I think the danger that we see in the clinic is putting too much pressure through the shaft of long bones,
Mm,
because not only do you have kids with underlying diagnoses like cerebral palsy or muscular dystrophy or even cystic fibrosis who have changes in their bone mineral density, but you also have a period of growth and development when bone mineral density is actually at its lowest, when the bones grow, but they haven't thickened yet. And so, one of the dangers I've seen is people who come in and try to use their adult techniques and they end up fracturing a femur, really,
wow.
is what it comes down to. And so, the thing you have to do is really work through the joint. There is, in terms of another misconception, is people are really fearful that they're going to damage the joint. But what we know from manipulation under anesthesia with kids is that they are far more aggressive and
Huh.
they don't create joint damage. And so we have these other pieces out there that can inform us. I even had someone tell me once that they would never mobilize a kid because they wouldn't want to produce a SCFE, which is a slip capital femoral epiphysis. And I'm like, well, if you look at what causes a slip capital femoral epiphysis, it's not joint mobilization. Like, this child is destined to have a SCFE, right? And so I think people just don't know what techniques are safe and who they can do them on, and who, when they need to modify it. And so kind of our next step right now is we're looking and saying, who can you manipulate, who can you mobilize, and then who can you facilitate. And really, at the end of the day, we're just trying to impact mechanoreceptors. And with kids, your joint mobility is not all usually as big of an issue as motor control or issues with sustained postures and fear. And so, your goals are different, what your challenges are different, and we just need to know how we need to modify that for children.
They're not small adults. It feels like there's a theme
They're
there.
not
They're not
smaller.
just tiny adults. So treat them
Well, and
differently.
I even remember in my fellowship, people who don't treat kids, when they think of pediatrics, they think of is that developmental neuro crew. And they're like, well, joint mobilization is not for them. You do kids, you do neuro. And it's like, no, there's a whole lot of orthopedics in a child, the
Mhm.
same amount of orthopedics that the adults have.
Sure.
And so not every pediatric patient has a neurological underlying diagnosis. Same with not joint, every neurological patient with a neurological diagnosis still has joints. And their joints move the same ways. But issues like spasticity, prolonged positioning, they affect the joints differently. And so you can't disregard an entire group because you don't know about it. And so my hope is to raise awareness, but really raise it from the standpoint of good foundational underlying knowledge of what the red flags are, and then give people an alternative to achieve the same thing.
Love that. Well, let's talk about some of that. You're developing alternative techniques designed around the biomechanics of the growing musculoskeletal system. Walk us through what makes these techniques different. I feel like a second ago we talked about anatomy and physiology being a little bit different, but some
Mhm.
similarity, some difference. What about the techniques makes those things different? You mentioned one, hey, maybe not putting the force through the bone. Are there others?
Yeah, so we really try to work through the joint, but also looking at combined motions. So a lot of times when we think about joint mobilization, we think of a posterior glide, we think of a inferior glide. We think about, but really when you look at the joint, it's generally it has motion all the way around it, right? And so looking at something like hip dysplasia, where you need to work congruently into inferior and external rotation in order to facilitate that joint being in the right position, and then activating the muscles. So really trying to understand that joint limitation generally doesn't happen in just one plane. And so we're looking to say, how can we work through the joint? And really, a lot of it is bringing in ideas that adult predecessors had. I mean, all manual therapy is done when you look at it over time, is everybody has kind of improved on or changed what the guy who did before them did, right? So it's
Sure.
not new rocket science. So we look at movement with mobilization. I would say that's probably the closest piece to it. There's a PNF mobilization technique that it's in the literature where you use PNF patterns with mobilization and facilitation. So, but a lot of those are adult manual therapy ideas and trying to bring that language into pediatrics and say, okay, now what are we seeing in these kiddos that we can apply these techniques to and add the word pediatric to it, pediatric joint facilitation, but it's not like we're the first person who came up with combined emotions and working at the joint instead of the shaft, right? So, and then really taking that into a motor learning piece, because at this point, until kids reach puberty, their greatest gains are coming in motor control and motor learning, sensory motor. Their brains are growing and they're learning. And so that's where the biggest bang for your buck is. So with kids, it's not about getting the joint in the right position and then doing a whole lot of straight leg raises and trying to increase the strength of the hip flexor and focusing on it from that standpoint. It's about training their brain to use their hip flexor to climb stairs now that they have figured out how to inferiorly and posteriorly glide. And so everything comes back into that movement pattern and the motor control that we want them to have, which brings us all the way back to the participation and activity component of the ICF, right? Because at the end of the day, with kids, we want to say, he can't climb stairs. We're not looking and saying this older woman has pain with hip flexion.
Right.
So we've got to think about it throughout the model and throughout the end goal of getting kids to be able to do what they do for a living, which is play and participate in their world. And so how can joint mobilization play a piece of that puzzle to achieve that end goal? And how can we give that tool to pediatric therapists in a safe manner?
Well, you already answered or took my next question. It was on the list. It was going to be a great radio segue, but you mentioned before, and there was always this question when I was a pediatric PT. At what age do we stop making it fun and about participation in sport instead of just gaining a few extra degrees of range of motion in this particular joint? And I think, that was the first rule from my mentor in peds was, if you can't make it fun, don't bother asking them to do it. And right. I think it's sad. Is it 18? Is it 21? Is it 25? All of a sudden we make it adult, and outside the physiology, people want to do stuff that has meaning and has fun or brings fun back to their life. I feel like 90% of what I did as a pediatric PT, maybe 95%, was obstacle courses. I knew what I wanted you to do. Let me figure out a fun way to make you do it, and then I'll reward you with a zip line at the end. But when you look at outcomes like that, does it change? I'm guessing it changes everything about what success looks like in pediatric manual therapy. It sounds like that's the middle of the ICF model for you, which is not, right. It's the child and the fun and the participation.
Right. It is all about when parents come in, they don't come in and say, hey, my kid, is it clearing his foot well when he in the swing phase? Right.
Right.
They come in and they say, my kid can't keep up with his friends on the playground and he keeps falling in the mulch.
Right.
And so you have to look and say, all right, why is this happening? And how can I make it where this kid can keep up with his friends or come closer to keeping up with his friends in the playground? So we bring it back, from the big picture down to but at the end, the test of whether or not we succeed is going to be looking at something like a 6-minute walk test. It's going to be these functional outcome measures that we say, did what we do make a change in an objective change in how he performed, which is then going to carry over into his world.
Yeah.
And so that's why I think pediatrics is so good at screenings that are functional and that are developmentally specific. Now, as we start getting into teenagers, we start to get away from that a little bit. But even then, just to give you an example, I'll get a gymnast who has low back pain and they can't do gymnastics because their back hurts and they're in danger of a spondy. So I come in here and I go, well, you've got terrible hip extension. And so by treating their hip extension, then I can make it where they're not as dependent upon their lumbar extension. And now they can do gymnastics and not hurt. Whether or not it's hip extension, they don't care. What they want to know is, when I do back handsprings, does my back hurt? And so you just have to, we can bring it down to that piece, but if we can't bring it back into play and activity and sports and interacting with our families, then all we have is a bunch of measurements on a piece of paper. We don't have any life change out of it.
There it is. Let's shift gears a little bit to chronic pain in kids. What do clinicians consistently miss about the role of parent beliefs, trauma, and adolescent development?
So chronic pain is such a fascinating topic right now, right? And it's another one of those places where people love to talk about it in adults and they're terrified to talk about it in kids. And pediatric therapists are generally terrified to treat it. And the problem that we have is that we have this biomedical model that we've been trained to in PT school that we try to apply to our patients with chronic pain, and we can't exercise chronic pain away. And so while movement is important for treating chronic pain, it is one piece of a probably 5-piece puzzle. And the other pieces that we need to train pediatric therapists in is to understand how the patient got there, how their brain is working, what the central involvement is. But also, one time I heard this word, the nocebo effect, and I was like, this is it. Because I can sit down with a kid and I can do pain education and I can do desensitization and I can help them understand pacing. But if they go home with a parent who had chronic pain all of their life, who then babies them and says, "Oh, baby, you don't need to go to school today. I can see it on your face. You're really hurting. You should probably just stay home and work from home. Or why don't you go lay down? You had to walk home from school. I know you're hurting." That nocebo effect that they get the other 6 days of the week, I can't compete with that.
Yeah.
And so we have to have a place where we can safely help parents understand the psychosocial side of chronic pain that is not threatening to them or disregarding their own experience. And you have to validate what the parent has gone through, but say the way that you've addressed your pain is not necessarily the way that science supports addressing it now and what we know to be true. And if you can't capture the parent, then the child is going to hear a different story the other 6 days of the week. And that's, and then the other piece is you have to get a hold of that underlying stressor. I have a patient who has been with me for a while, and he has a legitimate diagnosis. I mean, he has a PARS defect, legitimate diagnosis, but he only feels pain in math class. And so he goes to the school nurse every day during math in tears, but he's scared to death of failing math. He has a processing issue with it. And so when he has the emotional response to the stress of math, the place where his body processes that is the place of least resistance, which is his low back.
Sure.
And so you look at that and you go, that's nociplastic pain, as opposed to nociceptive pain, which he would say, he plays baseball. You know, that when I throw the ball and I rotate to the right and extend for my windup, I feel it. That's nociceptive. But I've got this underlying condition that I've been dealing with, and I look really, really good in the clinic. But when I'm in math, my pain's an 8 out of 10. That's nociplastic.
So what do you do with parents there? Or both of your patients, because I was taught that. They're like, your patients aren't just the kids, you're inheriting parents as well. And that's a good thing. Make it hard. But how do you do that? Because I'm sure there's clinicians who are parents listening going, "Oh yeah, magically when it's time to go to math class, things hurt," right? Where do you start that education? I mean, I guess, where do you start? I have no idea. Unwrap me that.
Sure. I think you validate what the child's experiencing, right? Because the parents will say, "Is my kid crazy? Is he trying to get out of something?"
Right,
Of
course.
You get past that. I always recommend psychology. We are not psychologists.
Correct.
But we can, psychology is hard to access for a lot of people.
Sure.
And so we can still validate, educate, and I think redirect to a new way of looking at and thinking about these things. So I say we have to lower his stress and level about math, right? And so you either getting math help or you let him know at the end of the day you're really not that upset if he doesn't do well enough. Like if we can lower those stressors in pain education world and P&E neuroscience education where they talk about this lion walking around with you. And the lion has all of these different words on it that are like my bills, my marriage, math class, my performance on the volleyball team, whatever it is, right? And that whatever your thing is, that lion is this constant threat to you that increases your pain. And basically you have to make the lion into a little cub. You have to make the lion safe and no longer threatening. And so if that means for this kiddo to say, it's okay if you don't get math, we're going to get you help. And even then, if you make a D in math, you're going to be a great person. And this is not a reflection of who you are. Like to bring down the threat such that if the people around me are okay with it, then I can be okay with it. When it comes to things like family abuse, I mean, in pediatrics, we have to be really aware of that and really sensitive to that and ask those questions. But those are all things that I say that I'm in 17. I never had a kid or had a patient who was a suicide risk until I started treating pediatric chronic pain.
Wow.
And now I would say we have one every couple months. And so it is heavy, and there's a deep psychological piece to it, which is why our pain clinics tend to, they include a psychologist because it's not this biomedical model only. While movement's important, it's a biopsychosocial approach as well, and it's a team approach. So it's hard, but then there are things we can do as therapists. As somebody, well, then why even send them to therapy, right? Like why not just send them all to psychology?
Right.
And there are things that we can do. Like movement does help. We are trying to change how we sensitize, like how sensitized the nerves are. Then we also I noticed that my kids with chronic pain all have a difference in their 2-point discrimination. And so I can address their 2-point discrimination, and I basically just rock back and forth. I'm like 2 points or 1 point, and if I know what their normal is and I can address that, they'll come back the next time and say, I had less pain this week. It's crazy, but it's about connecting their brain to that part of the body in a way that's not smudged, it's not haywire. Wow. And so there are things that we can do like that. Our kids with Ehlers-Danlos, they really lack proprioceptive control and feedback because their ligaments are so lax. And so if we can help their joints talk to their brain and their brain talk to their joints, then we can make a difference. But it doesn't happen in 6 to 8 weeks.
Sure.
It takes a lot longer, and but there's not many people who are doing it. Like I have patients who drive 2 hours to see me, and my coworkers easily have patients who drive just as far to see them because there's not pediatric therapists who feel confident treating it.
Sure. Let's go to the clinician who's listening right now. For the clinician who's listening, who has tomorrow, who has a child with pain or mobility limitations on their schedule, what's just one thing you want them doing differently right away with that kiddo on their schedule tomorrow?
So I think one of the things that we've learned with kids that are different from adults is with adults, we say, correct the dysfunction. And once you correct the dysfunction, then they will move better and they'll feel better. With kids, they want their pain, the kid and the mom wants their pain addressed first. So I always start with those grade 1 and grade 2 mobilizations actually away from the site. And I really want to bring down their pain and build their trust. If I go in with a kid and immediately go straight to the joint and start getting aggressive with it, if it's a nociplastic issue, or if it's a pain issue, I'm going to send that through the roof, right? If it is just a positional issue, then I may correct it, but they may come in with more pain. A lot of times they'll say, I felt great for 24 hours and then it hurt worse. And that is that just immediate pain relief because of the chemical change. But I have to build the trust of the patient. So there is a psychological piece to it. So I usually start away from the joint And then if I feel the need to correct something, like I'll do a lot of SI joint manipulations. I probably won't do that on the first visit. I will start by just springing the SI joint because they've got an adult putting her hands on their butt. You know what I mean? And so for a kid, that's strange. So I've got to really just think about how am I approaching this person, this little person, and their ability to process what's going on in their world as much as fixing this joint. And in adult, I think we fix the joint. And in pediatrics, I think we treat the person a little bit better. Not that we shouldn't in adult, but
they're not small adults.
They're not small adults.
You ready for lightning round? I did not prepare Ginny for lightning round. Are you ready for lightning round?
I'm ready for what I'm ready. I mean, I'm as ready as I'm going to be.
You're a PT. We'll figure it out. All right, lightning round. Yeah. We'll do myth or fact, pediatric edition. I'm going to throw something out. You tell me myth, fact, and maybe a sentence or two why.
What if I get it wrong? Do you already know the answer?
Wrong?
Okay.
You're the authority here. All right, myth or fact, lightning round. Ginny, kids are too fragile for joint mobilization. Myth or fact?
Myth.
Why?
Because it's more about how you do it than what you do. And you can treat the joint and treat it differently, and the kid be completely fine.
Myth or fact? Pain in kids usually means tissue damage.
Ooh, usually. I would say that. Oh, you're messing with me. Okay, so there's a whole thing. Pain does not mean tissue damage.
Okay.
Because it's at the brain. But
right.
Nociceptive pain usually originates with some kind of damage, but pain as a whole, no.
Right. Okay. Last one. Teens exaggerate chronic pain for attention.
I don't think that's true. I think
so that's a myth.
That's a myth. They want to be with their friends. They want to participate in their world. And
all right. Last thing we do on the show here with AOMT is called Words of Wisdom. What's the last idea, concept? What's your mic drop moment, Ginny? What do you got for us? What do you want to leave the audience with?
Do I get a second?
Sure, you get a second. I'll play the Jeopardy music right now.
Yeah, I mic drop moment. And gosh, you're killing me.
I got one for you. I know what it is. Kids aren't little adults.
Kids aren't little adults. I mean, they're really not. And also, I mean, if there's something that you don't know about, don't just throw it out. Investigate it. Ask questions. Learn about it. I think people, that would be the biggest thing is people who are just an absolute no. And you're like, have you ever been trained in this? Have you ever read an article? And I think give yourself a chance to learn about it, because then you might really be able to help somebody and make a difference.
Ginny, thanks for doing what you do. And thanks for talking to us here on Hands On, Hands Off through AOMT.
Thank you for having me.